want to address this question to the specialist in Oncotherm. My brother died in 2009, brain cancer. We are in the world of quantum physics. Once people start to see what to do with it, they will have the ample opportunity to see how it works. It's paradoxical, as I can say, but it works. The question I would like to ask the panel, if you take the spectrum as a whole, would this Oncotherm unit be the treatment other than the conventional way of doing things in the past, as in chemo and all that? Will it stand alone?
Can I start? Yeah. Yeah, I agree with Dr. Minar because oncothermia can improve results, but an important thing is that without toxicities, because patients feel better, it improves quality of life. So it's an important tool we can use to improve our results, combining with chemotherapy, radiotherapy, immunotherapy, but without side effects, because we want our patients to live a long time, but also with good quality of life. So I think it can be interesting to combine the treatments.
Just to clarify the background of what he was saying, doctors, our brother died at 54 years old with glioblastoma. He had a debulking procedure in Florida hospital, and he died 11 months later. We were trying to get him a cure, even in the US. And I didn't find Oncotherm at that time. So probably, if we had Oncotherm, that was what I was quite interested in its response, the effect of glioblastoma in the treatment of glioblastoma stage 4. Well, that was the background of his question.
Maybe I can quickly also respond to this by saying, first of all, I can feel the loss. I feel sorry about this. And I heard 2 to 3 approaches now using Oncothermia. Even there are data from a randomized trial from Spain that radiochemotherapy can be enhanced. We are following up on that with other trials. Also, we heard that there can be a maintenance treatment using that maybe after completion of radiochemotherapy in the future as a maintenance therapy to prevent any relapse. And also we heard from London that they are testing this actually neoadjuvantly combined with immunotherapy. So this is a complete different approach. And I think in the future that can be beneficial for GBM patients, the MEHT treatment.
Thank you. I'd like to elaborate on that because it's an excellent point. We must remember that the management of cancer is, what we want is for cancer to be managed as a chronic disease, which means that we need a chronic and sustainable treatment. And the best way to do that is to train the immune system to continuously recognize that. Yeah.
Yes, hello, good evening, ladies and gentlemen. I have a question. So I've noticed that adult patients were discussed here earlier, and I would like to ask if there are any cases involving pediatric patients. If yes, what was the age bracket and what were the response to the procedure based on some cancer classification and stages? And if none, has there been a clinical trial done or at least a feasible study conducted on pediatric patients?
Yes, we are conducting a phase 1, phase 2 study on pediatric brainstem tumors, and we are treating children. Our age bracket is 3 to 13. Younger than 3 becomes very difficult to get the child to lie still. From the age of 3 onwards, we can entertain them with comics. We have a TV. The parents are in the room. It's a very safe procedure, and we make it a very fun environment. A lot of the patients are sedated for radiation. So sometimes we have to change sedated for radiation. So sometimes we have to change the protocol and give the hypothermia after radiation. But we don't want them to be too sedated for the hypothermia because they need to be able to tell us if there's any pain or discomfort. We start at half an hour. Not many of the children can lie for longer than 45 minutes. The older children can, but the younger children struggle. What was the other question? I think there is a few more questions.
If none, has there been a clinical trial done or at least a feasible study conducted on pediatric patients?
Yes, so that's exactly what we are doing. And
Uh-huh.
at the moment, it's the study is limited to brain tumors,
Mhm.
but we have treated other regions of the children as well.
So how are they so far after the treatment?
They're fine. There's no difference in toxicity if they've had the Oncothermia treatment or not. They're
mhm.
doing well. We haven't reached 2 years post-treatment yet for any of the children. We only started in the middle of last year. So once we start reaching 2 years post-treatment, we'll have some
Okay.
results.
That's good to hear.
They're all
And-
alive, by the
Mm,
way, so
okay.
far.
Okay. So another question. So what are the most common side effects after the session or the therapy?
Pardon, what are the most?
What are the common side effects or
We haven't had any.
you
No,
haven't?
we haven't had any with the children, no.
Okay, that's good to hear.
I can maybe add to that if I'm allowed. There's a specialized center in Germany for hypothermia in children. It's not the Charité. We are also doing this, but it's in Düsseldorf. And a fellow colleague of mine, he's called Wesolowski. I can send you the paper. He conducted some research on non-seminomatous germ cell tumors that had a bad outcome after PI chemotherapy. So they were either directly relapsing or quickly after the chemo relapsing. And they were treated then by hypothermia and the same chemo, the same non-effective as a standalone treatment chemo. And he reported this was some years back in Lancet Oncology, that there was actually 80% of the kids then having a benefit of the same chemo where they were actually without hypothermia resistant to. So this is, I think, an important piece of data. And so sometimes according to that protocol at the Charité also, we treat little kids like 2 years old or something.
Mhm.
For that, we have to have them in full anesthesia with a team, and this is also feasible. And then sometimes because under anesthesia, the kids cannot respond when they have pain, then we see maybe a burning in the skin that can be, but this is also not a big deal then.
So there will be less trauma for them.
Excuse me?
Less trauma for them after the session.
Yeah.
Okay, thank you.
Is there any standing protocols available for new users of new users for like new cancer centers that we intend to distribute Oncotherm to? With respect to what kind of wattage shall we use for what particular type of malignancy, and if so, can we be provided with the same, considering you are the considered experts in this field of oncology, would there be like, say, if the patient is less than 10 years old, you have to start with this wattage. If the malignancy is, say, beyond a size for breast cancer, for instance, or if it is a bodily cavity cancer, a pancreatic cancer, intraperitoneal or retroperitoneal organ, would there be like uh, algorithmic protocols in the management that we can employ when we start using this? Thank you.
Yes, absolutely. So whenever a new user receives a machine, they'll undergo extensive training from Oncotherm, and part of the training is the medical training. And we're continuously um, evaluating all the data as it's published and putting together protocols. So for example, we know that twice per week is better than once per week when we combine oncothermia with radiation. We know that if the patient has had SBRT, they should have 2 Oncotherm treatments post-treatment. So there are protocols that we are learning from the literature continuously, much the same as in radiation, we're continuously learning and evolving. And when you trained, then we provide all of that. So for many locations, there are strict protocols. For example, the brain and children, you start at a low wattage and increase the power at a certain rate. Certain regions are treated for half an hour to start with. Certain regions are treated for an hour and a half. But all of that is in the protocol. But it's not an algorithm, unfortunately. And we're continuously learning as we go. But overall, what we want to achieve is as high a power as possible, with the patient's feedback being the level at which we stop increasing the power outputs. If, and it's very uncommon, but if it happens that the patient absolutely can't tolerate a high power, then we increase the duration of the treatment, but that very seldom happens. And in general, we want to reach more than 400 kilojoules in one treatment, except for the brain or other sensitive areas. But we have a manual for that.
Thank you.
Anyone in the group, I'm just wondering about rectal cancer management in the neoadjuvant setting. You have the 3 modality, you have the, what we used to do, of course, is radiation and chemo, right? Neoadjuvant. Now, if you have now oncothermic, the oncothermic modality, what would be a good protocol for rectal cancer in the neoadjuvant setting? Will you use the 3 modalities or just 2? Only 2? Which one would be better? The traditional or now with Oncothermia? So.
Okay, yeah. So there is a very interesting randomized trial. I think Piros and I think Marcel also shows some results which is a phase 3 trial comparing chemoradiotherapy, neoadjuvant chemoradiotherapy versus chemoradiotherapy plus modulated electrohyperthermia. It was very interesting because they gave in the first group, in the conventional group, they gave 50 grays to the patients with radiotherapy, which is the standard treatment. And in the group with hyperthermia, they gave only 40 grays, so 10 grays less. And they had significant better results regarding toxicity to the bowel, because the dose was lower, but they also had significantly better response at the bigger tumors which were more than 60 cubic centimeters had significantly better response. And that is very interesting because with lower dose, you have better results when you combine with the hyperthermia. So what we are doing, at least in Spain, is that we treat the patients with a standard chemoradiotherapy combined with the oncothermia 3 times a week, Monday, Wednesday, and Friday. And we are having very good results because we are increasing the rate of complete response at surgery.
do you now change the optimum time for surgery with the with the new protocol, or is it just the same?
It's the same. What happened is that we are having like some problems with patients because as we are improving a complete response, some of them
No.
doesn't want to
Oh.
have surgery. And we are following them and treating them with oncothermia. We don't have scientific evidence, but they say, okay, I prefer being treated maybe every 6 months with some treatments. And we have two patients. One, I think, was treated for the first time 2 years ago, and another one like almost 1 year, and they doesn't have recurrence. Although I recommend the patient to have surgery, but they don't want to have surgery because they say, okay, I have complete response, I prefer waiting.
So, yeah.
May-
yes.
Maybe I can briefly add my opinion. You're touching a great point because rectal cancer, we want to go for complete pathological response. We sometimes even consider whether the surgery is actually required when we have a total neoadjuvant therapy. And there's so some preliminary data from phase 2 trials from Germany, from 2 centers, from Erlangen, which is the epicenter of the neoadjuvant fractionated radiochemotherapy, and from Tübingen, suggesting that the pathological complete response after the standard 5 weeks radiochemotherapy can be significantly uplifted if you add hyperthermia. So there are then some questions whether we use the 50 gray or the 5x5, which chemo, how long should we wait to the resection? But it is clear that if you use standard radiochemotherapy and add hyperthermia, you lift up the proportion of patients having a complete pathological remission, giving maybe in the future some room for some surveillance of patients with a full clinical response, even without surgery for rectum cancer.
I think that's the way to go right now. A lot of us, even for colorectal surgeons, so we'll soon lose our patients to radiation oncologists and medical oncologists. But for the patients, I think it's most of them would not like to have surgery anymore, especially if the tumor is very low down in the anus. No? So I think that's a very good, for me, it's a very good thing that has happened in the management of cancer. So corollary to this, we have patients who have already exceeded their radiation. There's a limit, of course, we know that, and then they recur, local recurrence. So is there a role for oncothermic treatment for these patients? Yeah.
I hope I understand well. Yes. My ideal patient would be actually patient treated with TNT now, total neoadjuvant therapy, accompanied by oncothermia for the whole duration of the treatment, and going beyond. We use still the 28-day protocol of 5FU and the daily radiation. And I think that's even better because we can give more hyperthermia. And if there would be a pathological or imaging, on imaging, we would see a complete response. Probably we would, and there is now an attempt, and in Hungary, in many centers, they are preserving the organ, so they don't operate now, and they are observing. Personally, I would be more convinced and happy with the method like circulating free DNA measurements. You know, now there are attempts, especially in colorectal cancer treatments, to tailor therapy to circulating free DNA. So if there is a negative result for that and imaging is also favorable, you can just follow up with that. And that's also in our hands. We see that it predicts the future much better. You know, imaging and tumor markers say the state of today by circulating DNA tells you 3-6 months in advance.
Correct me if I'm wrong. So this treatment modality now can be used on a PRN basis. There's no toxicity whatsoever. So you just keep on going. Like if the patient really doesn't want an operation, so just close surveillance and then as needed, give oncotherapy oncothermic treatment?
Definitely, yes.
Yes.
If I may, just with regards to the reirradiation, we have a review of 6 studies where hypothermia has been used for reirradiation, oncothermia included. And in terms of the hypoxic tumors, we know when a patient is irradiated and there's a local recurrence, that the recurrent tumor is hypoxic. We presume that it's mostly because of damage done to the vascular bed. And so adding Oncotherm treatment to reirradiation is absolutely beneficial. We have 3 protocols at the moment that we employ with radiation. We either do a 50 gray protocol, depending on when the patient was last irradiated and where, or we do, there's the BMC, the BVI and the AMC protocol, both developed in Europe, and they're both hypofractionated protocols, where the patients have either 3 weeks or 4 weeks of radiation, 2 or 3 fractions a week, combined with hypothermia. So those are the protocols we use, and the decision as to which one to use is based on where the tumor is.
Just one more question. This time about prostate cancer, because we have a very high incidence of prostate cancer in the Philippines. And sometimes we treat patients with rectal and also prostatic cancer. So I am very much impressed with the results of prostatic treatment with radiation. My patients are very, very happy with the treatment. And most of them, they say that I should have done this and not gone through surgery anymore, because the results are really outstanding, especially with the new radiation equipment that we have. So my question is there a major role for prostatic cancer with this modality? Yes.
Well, you're asking whether there are prostate cancer trials?
Yes. Can it
Okay.
treat prostate cancer?
Yeah.
Can it treat prostate
You
cancer?
you can, because most of the data that we have is actually on pelvic tumors,
Yeah.
including cervical cancer, and the prostate is good reachable both by heat and of course by the electromagnetic fields. I personally, working on radiation, I'm specialized on prostate cancer. What we see mostly nowadays is that patients come with a PSA recurrence. So because the primary prostate cancer, they like very much to get prostatectomy. That's why I have a trial. This is using a different hypothermia device, but it doesn't make a difference. So we are using standard salvage radiation to the prostate bed plus hypothermia. And we included 100 patients, mostly finished the recruitment. We published already that the first 50 patients had no unexpected toxicity. So again, and we hope that we can, when we analyze the whole cohort of 100 patients, then see some benefit regarding the PSA control, but this is not yet the case. And of course, then in primary radiation therapy, then you have chances to include the hypothermia as well. For instance, I would say in intermediate risk disease, where it's always a question, do you need anti-hormonal therapy or not? This is toxic to the men to get rid of their testosterone. So if you can offer something that is also boosting the radiation locally in an order of 15%, as we see, then this can be very attractive, I believe.
How about, sorry, I said last question. How about complex pelvic tumors involving, let's say, rectum, bladder, uterus, and the only way to treat them will be an exenteration. And of course, very few would really want to go to have, to have pelvic exenteration. It's a formidable procedure. So do you have any experience with such tumors, and how do they respond with the response of these tumors to combine treatment, perhaps with oncothermia also?
May I just start? Well, we have some experience with gynecological tumors as well, with good results. Extracervical, I would say. So uterus, uterine, and ovarian. Yeah, when they're infiltrating the pelvis, that's what we mean. Yeah. Yeah. So the problem is, I think, maybe it's a too long shot, and I will let the others talk as well. That, you know, as a pathologist, I can say I looked at thousands of samples, but I don't know what a tumor is. So that's a problem. And as I have seen here, you know, with hyperthermia, we might also prevent the tumors from regenerating. By this means, I mean that, you know, stopping these homologous recombination repair. I think we converge to some kind of molecular systems or circuits in the tumor where there is BRCA dysfunction in repair mechanisms. I think also Paul showed PARP inhibitor. So PARP inhibitors are mostly used in ovarian and prostate cancer in our practice. And I think the most beneficial effects are with these patients somehow. So and that's I think one point. And as mentioned, hypothermia is actually a biophysical, or modulated electrohypothermia has biophysical basis. So if you had a deeply infiltrating pelvis mass, I think you can expect a tremendous effect there, because it's because of the amount and volume of the tumor on one hand. And on the second hand, you get all these tumors there. So depending on your primary, you have more chance to have all these defects also affecting them to some degree. But maybe I'm just a bit puzzled on that. Go on.
So I think if I may just to understand the question better, if the question is on a complex tumor involving the bladder and the rectum, if you're concerned about the safety and toxicity to the bladder and the rectum, as Dr. Marcel was talking about the gynae results, with our cervix patients, 50% of them were in stage 4A or B, so they all had rectal and bladder involvement, and we did not see any increased toxicity. We did not see any increase in fistulas as a result of the addition of Oncothermia to the chemoradiotherapy. If the question is, can Oncotherm be used in place of the surgery in order to prevent having the surgery, we have no literature for that. And as a general rule, we avoid recommending Oncothermia as a replacement. It's only used as a monotherapy if there's no other options, or if the patient is very resistant to the treatment for which we know there's a better outcome. The other thing with prostate cancer, typically, especially your low Gleason score tumors, they are very slow growing. So when we say there's a better effect because of the higher metabolic rate in more aggressive tumors, what we mean is the effect, we see the response faster. So, but that goes to aggressive, it speaks to aggressive tumors anyway. If a person is only expected to survive 6 months, it's easy to study them for 6 months. But in prostate cancer, if a person is expected to survive 10 years without treatment, we don't have the resources and certainly haven't done the studies.
Maybe I would like to pick up that you mentioned bladder cancer, because it's important in our practice to provide organ preservation here, if possible. So what we do is the so-called three-modality treatment. So like a small resection of the bladder tumor, if it's localized, and then apply radiochemotherapy. And we do that with very good results to the bladder, actually. So, however, the salvaged cystectomy rate that the patient would progress locally and then would require this large bladder taking out surgery is around 1/3 of the patients. And we learned, I didn't mention it, but what we learned using a different hyperthermia method, but again, it doesn't matter because we can heat up the pelvic, the bladder very well because it's containing fluids and it's getting really warm. And also the other effects that we discussed in detail, anti-cancer effect, come into place. So we have a tetramodal therapy for treatments, including hyperthermia, and we published data that with that, the salvaged cystectomy rate goes significantly down, like to 10% only. And this is major finding. But you know, what you often get from referrals from the urology is the really non-technically operable patients like T4 and plus, maybe metastatic. And we know that these more advanced tumors, they do not respond that well. So what we really need to get the best results for hyperthermia is the confined T2 and 0 disease. This is also clear from the data. So what we can do here with hyperthermia is do an extraordinary treatment. But from my perspective, what we cannot do, if you describe this catastrophic scenario with all the pelvis being a tumor, I mean, this is clearly a palliative case and we can probably not turn it around. But this is not what anybody would expect from us, I guess.
Thank you.
We also very quickly have a phase 3 study on bone metastases, prostate cancer included. I mention it just because you were speaking of prostate cancer. So palliative treatment, radiation with or without hypothermia twice a week. And the results were so significant that the study was stopped early because the patients with hypothermia had significant improvement in pain.
First of all, I would like to commend the group for giving us this very valuable opportunity in educating us with the concept of the abscopal effect. I find it very interesting. To be honest, I just read this in the usual pathology textbooks. In line with that, I hope I am following correctly. Are you saying that patients with metastatic disease, with multifocal or multicentric metastases, and unresectable primary cancer are treated by placing the probe on the main area where you have the primary tumor or where you have the bulky tumor, and the rest of the foci, metastatic foci, will be addressed by the abscopal effect? Is that correct in the way I understand this?
When combined with radiation?
Yes, combined
We
with radiation, yes.
absolutely saw that in a quarter of our patients. So that's what I'm saying.
Because at first, earlier, when I was, listening intently at the presentations, my mindset was that, I think in the case of Doctora Arojo, her personal experience with your mom, my mindset was that you would apply the probes on all the foci. I think that's rather, cumbersome and, impractical. But I understand you just did that on a personal approach. So now I see that that is not the case. Rather, you would rely on the abscopal effect to take care of the rest of the other foci. So is that correct in the way I understand this?
What I try to do is I try to treat as much as possible if we have multiple metastases, but sometimes it's impossible to treat everything because it's too long, are many metastases. So what I do is more or less to have a 3-hour treatment the longest, because otherwise for the patient it's going to be very hard because we have that abscopal effect. But if you can treat directly more lesions, my experience is that you have better response. So what I think that it can be interesting is what I presented for MD Anderson in Houston, that maybe you can, if you can, for example, combine the treatment with radiotherapy and give high dose to one lesion and low dose to the other ones, you will have more abscopal effect. So what I usually do is I treat as much as I can but usually cannot treat everything, and one part of the body is going to respond with abscopal effect.
Yes, ma'am. Go ahead, please.
No, just to elaborate on that, the only reason we didn't treat distally is because in the cervix patients, it was part of a trial, so we had to follow the trial protocol. But absolutely, if you have the opportunity to treat more lesions, you could either treat 1 hour, 1 hour in a row, or what you would learn when you do the training is we don't give oncothermia 2 days in a row. We usually leave 1 day in between for various immunological reasons. But if you're treating multiple lesions, you could treat, say, the pelvis today and the thorax tomorrow. But as Dr. Elizabeth said, absolutely treat as many lesions as you can.
Right. In line with that, I think there was a mention earlier, I don't know if it was from Dr. Mulholland, about advanced pancreatic cancer, where you have your ascites. I can simply ponder how will you apply the therapy for patients with that? You have, ascites, and the peritoneum is washed with all these malignant cells. How exactly do you address that? I mean, with this modality, oncothermic modality, how will you address patients with advanced pancreatic disease with, ascites or peritoneal carcinomatosis?
What I think Marcela spoke about that, but what we try to do is to drain the ascites. We put sometimes a drainage to take out the liquid, and we treat the patient without many problems. And one important thing is that you usually see soon a good response, and the patient begin decreasing the ascites level. So they begin decreasing the liquid inside the belly.
I think if the ascites is very bad, we drain the ascites beforehand. But in advanced disease, the ascites comes back fairly quickly. We haven't, in our facility, we haven't seen any adverse effects by treating patients with the ascites, for example, liver or pancreatic disease. So we continue to treat, we just try and manage it as palliatively as possible. There is recently a paper that's been published on the management of peritoneal disease with SBRT, treating multiple lesions versus cytoreductive surgery. And HIPEC has obviously been used with cytoreductive surgery, and that's heating, flushing the abdominal cavity with heated chemotherapy, usually cisplatin or mitomycin. So I wonder, perhaps it's a question for Dr. Elizabeth, I wonder if we could do SBRT combined with modulated electrohypothermia for peritoneal disease.
Yeah, we have done that because you know that the bowel is very radiosensitive, so we cannot treat usually the bowel. But as I said in my presentation, is something related to the dose. So we are doing SBRT on peritoneal carcinomatosis when sometimes the patient doesn't have any other option. And what we do is we give like a small dose of radiotherapy to the whole belly of the patient, the whole peritoneum, and SBRT to some spots combined with the oncothermia. And we are having very good results because we have partial response or a stable disease. So we will publish this more or less, I think, in 6 months or 8 months to have more follow-up. But this is very interesting. We are doing that.
Thank you very much.
Just to share, doctors, the electrode that was sent to us is small and medium. And of course, if I look at Balaz, I think even the big electrode will not fit in one chest, one lung alone. But in a 75-kilo adult male, the electrode practically covers the whole chest and partial to the abdomen in a Filipino size patient. So that will answer the question on multifocal lesions. Uh, the patient that we are having has a liver and a lung metastasis. So I point as directed. I have placed the electrode on the chest, and it actually covers the region of the liver. And I place the electrode on the abdomen. It practically covers the rectum and the nodes of the mesenteric nodes. So practically, because of the Filipino size, the electrode covers even multifocal lesions. That's what I like to share. But of course, that is totally different for the sizes of 6'5" and everything.
Yes, thank you so much. Yes, the electrode size, the three type of electrodes available for the HY 2030, the 20, 30, and 40 centimeter. The 40 centimeter has to be enough big to cover primary tumor, a metastatic area as well. And I think maybe the Philippine population is a little bit smaller than the European population. That's why I think the electrodes could be enough to cover all of the lesion which need to be treated.
And I think it's interesting to add to that sometimes when we see a very big patient because he's obese and has a lot of fat, the fat is outside the bones. So when you want to treat the lungs are the same size that in a thin person. So because the fat is outside, so you have to put the electrode in the center because you are covering the lungs, because the other part is fat outside the thorax. So you have to take that into account also.
Good evening. I specialize in trophoblastic disease. And did you have any clinical trials regarding gestational trophoblastic neoplasia, which is a very vascular tumor? And is there any possibility that Oncotherm has an effect in a very vascular tumor? What is the possible, if ever this will be um, placed in the Philippines? I think it's a good idea here, especially in gestational trophoblastic neoplasia.
As far as I'm concerned, there are not trials because I treated one case, but at the end, oncothermia, modulated electrohyperthermia is good for almost any tumor, any solid tumor. So it's a good combination. And in those tumors, they have a lot of vessels, but are bad vessels. So the problem is that chemotherapy cannot go inside. They are very hypoxic. So the patient I treated went well, had good results. It was combined with chemotherapy, but I think there are not common, so I think it's difficult to have that.
Yeah, it's very rare, especially in the high developed countries. Thank you.
Any more questions from the group?
I want to zero in on that last question I have asked you earlier. I have seen 3 of my best friends undergo chemo with devastating effects. If you zero in on this question, and if you, all things considered, if you take the whole spectrum as a whole, will you negate the need for chemo? It's a yes or no question.
Did you ask, are we understanding, are you asking, can we negate the need for chemo altogether? Again, I don't believe so in all cases. We have a study in cervix where patients were treated with radiation with hypothermia versus radiation and cisplatin as a radiosensitizer, and the results were equal in both groups. So in principle, based on those results, if the patient is not eligible for chemotherapy, there's very good motivation that you could have the same outcome with hypothermia. We're entering a very fierce pharmacological debate and industry debate. If we start saying that we should replace chemotherapy with oncothermia, certainly we can improve the outcomes. We would have to do trials where we show chemotherapy, radiation with or without chemotherapy and with oncothermia alone. And that becomes very tricky because from an ethical point of view, it's difficult to design a trial where you are not including standard of care and comparing substandard of care with a new treatment. So developing those trials is very difficult. And we do know that in some instances, certain tumors, malignancies are very responsive to chemotherapy. So for example, in testicular tumors, where they are so responsive to the chemotherapy protocols, it would be difficult to motivate removing the chemotherapy and just treating with oncothermia.
Maybe.
Any more
maybe I
questions
can
from the
add,
group?
For cervical cancer, so we have data, randomized data on radiation plus heat versus radiation alone. And then there's other trials that radiation plus chemo versus radiation alone has same effect. So what you are asking for a disease where the chemo is only used for radiosensitization, then actually the question to your answer can be in part yes, but it will be will be requiring trials. And exactly in other situations where the tumor is more aggressive, like pancreatic cancer, at our center we are a little bit conservative. The patients who are inoperable, they undergo chemo, intense chemo, because we know there are even some patients progressing under intense chemo. And that's not the people that we want to treat locally. But if you give intense chemo and there's only local disease, then it's worth to intensify local therapy in those patients, for instance, radiation of pancreas plus hypothermia. So in this situation probably, and many other situations, and chemo is a substantial part of the oncologic therapy. Sorry, I didn't want to interrupt.
It's the same. I was going to add that in the European guidelines for treating cervical cancer, they recommend that if the patient is not candidate to chemoradiotherapy, because it's not candidate to chemotherapy, they recommend combining radiotherapy plus hyperthermia because the results are equal.
This is the last question. Depending on the jurisdiction, how do you classify oncothermia with respect to oncology? Because I have been asked that question. Is it under rad onco or is it under medical oncology? Or is the answer neither?
In Spain, is under radiation oncology. By law, you have to be a radiation oncologist to prescribe the treatment, and is in the program for the residency, you have to learn hyperthermia, so it's under radiation oncology.
Is that notwithstanding the fact that oncothermia does not have radiation?
Excuse me, could you repeat?
Even I'm saying even if oncothermia does not emit radiation, it would still be under rad
Yes.
onco.
Yes, you have to be radiation oncologist because you are using waves. So it's something like similar, different, but similar to radiotherapy. So medical oncologists in Spain cannot prescribe hyperthermia nor oncothermia, which is modulated electrohyperthermia.
Thank you. Would there be any other
Yeah,
answer in other jurisdictions?
in South Africa, because it's a class 2B device and it doesn't emit ionizing radiation, it's not regulated by the Radiation Oncology Society, but rather by the overall Oncology Society. So both medical and radiation oncologists can prescribe it. Nurses and radiation therapists can administer the treatment. In fact, medical oncologists, sorry, medical doctors can also prescribe the treatment, although they can't prescribe the concurrent chemotherapy and radiotherapy, so it's not common. But 80% of our patients are radiation oncology patients in any case. Very few patients are strictly medical oncology patients.
In Hungary, both specialties can and are allowed to use actually both radiation and medical oncologists. I think radiation oncologists understand probably much more better, because of the basis of their education and the physical and biophysical basis they have. We have to admit, as medical oncologists, that they have a much more thorough knowledge about these effects. And although András is here, I don't know whether he can talk, but from his perspective, I would probably also ask him how he thinks about this. And but as mentioned, it's the fifth pillar. That's my personal thought on this of oncology.
Can we hear what's going on in London, in England, Dr. Mulholland?
So yeah, at the moment, I had the first EHY 2030 device,
Sorry
and I'm a
about
med.
that. Let's put some audio, please.
Sorry, Paul, could you repeat your answer because we didn't hear you?
Yes, I had the first EHY 2030 device. I'm a medical oncologist and I prescribe it. I think that the device is straightforward to use. I think that it's good to have both medical and clinical oncology involved in developing the device. My perspective is going to be different to radiation oncologists. I'm very focused on what is it doing to the immune microenvironment and what's the immune response to it. So yeah, I think both medical and clinical oncology should be using the device.
I fully agree with Paul that this is an interdisciplinary care that we do to the patients, and nobody should be excluded. Also, it's very important that also medical oncologists are part. In the reality in Germany is a little bit compared to South Africa, same 90% radiation oncologists, maybe because they have this local therapy more in their mind or something in their mindset. But however.
Good. So colloquially, we can say it's up for grabs, dependent upon your geographic location. Everyone's support here is vitally crucial in fostering collaboration and innovation within this medical community. And so let's give it up for all our esteemed and prominent guests. Let's clap our hands for our guests for tonight. Thank you so much.